colleagues to the first day of our first annual OncoAlert Colloquium. Along with our partners of MASCC, COG, eCancer, and BJ Oncology, we bring you the first of its kind year-end review for some of the biggest news in oncology for 2020, divided by tumor group. OncoAlert is an oncology network of medical, surgical, and radiation oncologists, oncology nurses, cancer researchers, and most importantly, patient advocates who fight cancer through the spread of reliable scientific information regarding cancer and cancer treatments, fortifying the voice of our patient advocates, and the promotion and creation of oncology education that is accessible to all. Our goal with this colloquium is to provide our colleagues with a reliable year-end review by some of our OncoAlert faculty who happen to be leaders in their field. The colloquium, like every OncoAlert initiative, is without sponsorship. Everything that you will see during the week is possible because of the dedication of our OncoAlert faculty and friends who believe that as colleagues, we can make a difference in education globally, regardless of financial possibilities. As you have noticed, there's no signing up, there is no registration, and this videos will always be found on our YouTube channel where links can be easily shared and encouraged to do so. Today's presentations are on GI oncology and mass sessions of supportive care. These best of 2020 presentations are colon cancer, Dr. Cathy Eng of Vanderbilt University, anal and rectal cancer, Dr. Andres Cervantes of the University of Valencia, gastric and esophageal cancer by Yelena Janjigian of Memorial Sloan Kettering, pancreatic cancer by Dr. Mark Lewis of Intermountain Health, what this means to the advocate by Dr. Manju George, Scientific Director of ColonTown. We follow up with the mass sessions of the Colloquium with neurological complications of cancer treatments by Dr. Maryam Lustberg of Ohio State, financial toxicity and supportive care by Dr.Ray Chan of QUT in Australia, and we finish off with supportive care and digital health by Dr. Florian Scotte of Gustave, Roussy. We hope that you enjoy this colloquium, and we invite you to join us for day 2, where we will be going through the best of lung cancer in 2020 and the COG sessions. Without further delay, Dr. Cathy Eng.
It's my sincere pleasure to present on behalf of the OncoAlert team updates regarding colon carcinoma for 2020. I'm Cathy Eng from Vanderbilt Ingram Cancer Center. So I'm just going to be discussing briefly about locally advanced colon carcinoma, as well as an update regarding metastatic disease. Focusing on locally advanced colon carcinoma, as you recall, about 104,000 individuals will be diagnosed with colon cancer this year alone. And historically, it's been a matter of discussion with stage 2 patients. And then for stage 3 patients, we had traditionally been providing them about 6 months of adjuvant chemotherapy. But at ASCO 2017, we had a presentation of the IDEA trial that was presented looking at the role of 3 months versus 6 months of adjuvant treatment. And just keeping in mind, this is part of the rationale for this study design, was that originally the MOSAIC trial, as you know, was a very successful study demonstrating the benefit of adjuvant FOLFOX-based treatment for approximately 6 months relative to single-agent 5-FU. However, the majority of patients still had neuropathy even up to 4 years out after completing their chemotherapy. And this, please note, is in the adjuvant setting where these patients are NED. So the IDEA trial was basically to demonstrate is 3 months non-inferior to 6 months in the adjuvant setting for disease-free survival. And basically, this trial was looked at only stage 3 patients at its original presentation in 2017. And please also note that this study was not powered to compare FOLFOX to CAPOX. This was the study design. Once again, if you recall from the MOSAIC trial, it was a 24% relative risk reduction by providing 6 months of adjuvant FOLFOX-based treatment. The purpose of the IDEA trial was to allow a 12% relative risk increase of death or recurrence. So your upper limit of normal for the 95% confidence interval was allowed to be up to 1.12. And this is what we mean when we're looking at the numbers in regards to the confidence interval. Anything that surpasses that on the right would not be considered non-inferior. And these were the original trials that were included in this pooled analysis. There were 6 trials, as you can see. Some of them included stage 2 patients, 1 included rectal carcinoma patients, and 1 originally included a randomization to bevacizumab in the adjuvant setting, and one also included a second randomization to celecoxib, as you recall, which was recently reported out, which did not demonstrate any benefit. But this was the result at the time, at the presentation in ASCO 2017, and unfortunately, investigators were not able to demonstrate non-inferiority for 3 months versus 6 months because the upper limits, the 95% confidence interval, was at 1.15. However, what could we learn from this trial? Well, we learned that for the low-risk group, the low-risk group was considered T1 through 3, or N1 disease, or node-positive disease. And for CAPOX, it demonstrated that this could be considered a non-inferior regimen for 3 months of treatment. However, for FOLFOX, that was not proven. And then there was a high-risk group defined as T4 or N2 disease. Now, we've had recent updates regarding all of these trials, and they have all been either published or presented in some form or fashion. And now we have a recent update at this year's ASCO, looking, number 1, at the secondary endpoint of overall survival, and number 2, providing an update regarding the primary endpoint of disease-free survival with a mature median follow-up of 6 years. And these were the demographics, no different from what was originally presented, of over 12,000 patients. And as you can see here, by providing 3 months of therapy versus 6 months of therapy, there was a significant reduction in neurotoxicity, as can be expected. And finally, the results for the secondary endpoint of overall survival. The hazard ratio was 1.02, with the upper limits of the upper limits of the 95% confidence interval being a 1.11. So this was a successful study. Furthermore, by looking at the regimen, as you can see here, by providing CAPOX versus FOLFOX, the Kaplan-Meier curves basically almost overlap. However, keeping in mind the hazard ratio was 1.07 for the FOLFOX regimen. And for the disease-free survival, which was the primary endpoint, you can see here for CAPOX, the hazard ratio was 0.98, and for FOLFOX, the hazard ratio was 1.16. So a change in disease-free survival at 5 years of -3.3%. What is also noted when you broke it down once again by low risk versus high risk, really almost an overlap of the KM curves for low risk, and then for high risk, a subtle difference of -1.7%. Now, when looking at high risk, low risk, and the type of regimen provided, basically you will note that for low risk patients, it is reasonable to consider CAPOX, and it is reasonable to consider FOLFOX. For a high risk patient, T4 or N2 disease, it would probably be recommended, based upon the data, that 6 months of FOLFOX be provided. However, it is reasonable to provide 3 months of CAPOX in the high-risk setting. So what can we conclude? So with prolonged follow-up, there was no difference basically in the KM curves for overall survival. And for low-risk patients, evidence supports the role of 3 months of adjuvant CAPOX or FOLFOX. For high-risk patients, T4 or N2 colon carcinoma patients, 3 months of CAPOX is reasonable, but 6 months of FOLFOX would be preferred if you choose that regimen. Now, they did look at the high-risk stage 2 patients, those with suboptimal lymph node dissection, poorly differentiated histology, T4 disease, and basically they could not demonstrate in their pooled analysis of the studies that were available that included stage 2 patients that there was non-inferiority for 3 months versus 6 months. However, an update of the TOSCA trial suggests that further follow-up would be recommended, and it appears to be that 6 months of FOLFOX would be reasonable in that setting based upon the updated TOSCA analysis. Now, for T3N0 patients, there's actually a clinical trial available. Energy GI005 is looking at the role of circulating tumor DNA as a predictive biomarker in adjuvant treatment for stage 2A colon carcinoma patients, also known as the COBRA trial. And we would highly recommend participation in this trial if you have it available to you at your site. Now, what about metastatic colorectal carcinoma? Well, at this year's ASCO, we had an update regarding the phase 3 Keynote 177 study. looking at MSI high, stage 4 treatment naive patients, comparing the role of pembrolizumab versus the investigator's choice of systemic chemotherapy. And there was an optional crossover to pembrolizumab for up to 35 cycles if there was evidence of progression of disease based upon RECIST criteria and central review. The primary endpoint was progression-free survival. And as you can see here, based upon the KM curves, the progression-free survival for pembrolizumab versus systemic chemotherapy was favorable at 12 months and at 24 months. What is interesting, though, is that there is some overlap of the KM curves, as you can see here, between 4 and 8 months of therapy, suggesting that initially systemic chemotherapy may have been beneficial. But as you can see here, the overall response rate was in favor of the investigational arm overall, as well as the overall PFS results, and the p-value was 0.0275. Now, what about the forest plot? What does it indicate to us about which type of patients may benefit more from chemotherapy? I think a lot needs to be teased out more about this chemotherapy study. However, there does appear to be some role for those patients that were initially diagnosed with a RAS mutation. And I think that is actually quite interesting. And actually, but overall, the results have demonstrated the benefit of pembrolizumab in the frontline setting of treatment-naive patients. The duration of response, once again, was in favor of the investigational arm. And the response rate was in favor of the investigational arm at 44% versus 33%. And these are basically the radiographic response in regards to target lesions and the waterfall plots. We also had an update about this year's Beacon trial, which, as you recall, was presented earlier and basically resulted in the expedited approval of the triplet regimen as published in the New England Journal of Medicine last year for patients that had been previously treated with a known BRAF mutation. And as you can see here, basically it was a 3-arm study looking at encorafenib, binimetinib plus cetuximab versus the doublet of encorafenib plus cetuximab versus systemic chemotherapy of FOLFIRI plus cetuximab or irinotecan plus cetuximab. And this was an international trial. The primary endpoint was overall survival. And as you can see here, when it was originally presented, the triplet was basically superior to the control arm. And please note that the triplet was not powered to be compared to the doublet. Each arm was to be powered to be compared to the control. And so here at the original presentation, the overall survival was 9 months versus 5.4 months. And for the doublet was 8.4 months versus 5.4 months. The objective response rate was in favor of the triplet of 26% versus 20% versus 2%. Now, we've had recent updated results looking at basically the triplet versus the doublet at this year's ASCO. Noticing once again that 9.3 months versus 5.9 months, and then for basically the doublet was also 9.3 months versus 5.9 months. So indicating that the doublet was just as good as the triplet in regards to benefit for this patient population for overall survival. And basically here is the overlap of the triplet versus the doublet in comparison to the control arm. In regards to progression-free survival, once again, very comparable at 4.5 months versus 1.5 months versus the control arm for the triplet, and the doublet was also 4.3 months versus 1.5 months for the control arm. Now, what is quite interesting is the Beacon trial originally suggested that potentially if you'd received your treatment earlier and had received less therapy, there appeared to be increased benefit based upon the subset analysis that was completed. Now, at this year's ESMO, the Anchor trial was actually presented, which looked at the triplet in the treatment-naive setting in a single-arm phase 2 study. And basically, this was quite interesting. So for a newly diagnosed BRAF mutant patient, the response rate was close to 50%. However, the progression-free survival was only 4.9 months. And obviously, this was a little bit more disappointing and was not what we were expecting. Granted, this is after median follow-up of 4.6 months, but I do not suppose that with prolonged follow-up, it would be significantly better by any means. Now there is, it should be noted that basically there is an ongoing phase 3 trial called the Breakwater study, which is looking at the role of the doublet in combination with chemotherapy versus the doublet alone versus systemic chemotherapy as well. And that trial will be open shortly before the end of the year. Now, I did want to mention the Mountaineer trial, and I also want to mention SWOG 1613. And why is this important? Because there's data that shows that HER2 amplification can have a significant role for our patients, and it should be tested in all of our patients that present with metastatic disease. This was the initial results from the Mountaineer trial, which is an ongoing phase 2/phase 3 study, and this was presented by Jonathan Strickler. So this study was a single-arm study, basically enrolled about 26 patients, as you can see here. The majority of patients had left-sided tumors, and about 38% of patients had 3+ HER2 positivity by IHC, and 61% of patients had HER2 amplification by FISH that was noted. In regards to response, the response rate was quite favorable, as you can see, for the role of tucatinib and Herceptin, at 52.2%, with a progression-free survival of 8.1 months and overall survival of 18.7 months. And these are basically the KM curves. So this trial is ongoing, looking at this combination in a phase 2 study at this time, and we would encourage enrollment. In addition, there is a second trial called SWOG 1613, which is also looking at the RAS wild-type patient population and the BRAF wild-type patient population. Centralized testing for HER2 must be completed, but basically it's looking at patients and randomizing them to either trastuzumab plus pertuzumab versus cetuximab plus irinotecan. If there's evidence of progression on the control arm, patients are allowed to cross over because the primary endpoint is progression-free survival. So I would encourage you, number one, to please test all your patients for HER2 amplification and also enroll them to a clinical trial if available. Now, I think this is quite interesting. This is a drug that was presented by Dr. Sienna looking at deruxtecan, which is a novel ADC drug designed to deliver an anti-tumor effect. And basically, this is a trial that was designed in patients that had HER2 expression, all RAS or BRAF wild type. They were allowed to have greater than 2 prior regimens, and prior HER2 therapy was allowed previously, which I think is of critical importance for those patients that have gone through standard treatment. Now we're just going to focus on cohort A, and once again, the drug was provided on a Q3 week dosing. Once again, patients had to be HER2 positive by IHC 3+, or demonstrate, or could be IHC 2+ with confirmation with FISH. And so basically, this was a small study of 53 patients, but I think it is quite important because, in fact, they demonstrated an overall response rate of 45.3% in this small patient population. And these were heavily pretreated patients. So this drug appears to have a role, and it's currently already FDA approved for breast carcinoma patients. And this was the change in tumor size. And as you can see here, the better benefit was seen in those patients that were IHC 3+. This was the progression-free survival of 6.9 months, and the median overall survival had not yet been reached. So thank you for your attention. These were just some updates from this year. There's a lot more topics to discuss, obviously involving rectal cancer and gastric cancer, etc. But these were updates regarding specifically colon carcinoma. I really appreciate your attention, and please feel free to reach out to me whenever you get the chance. I would appreciate it. Have a happy holidays.
Hello, everyone, and thank you for inviting me to give these highlights on rectal and anal cancer in 2020. So I would like to thank my colleagues in OncoAlert for this kind invitation. I would start with rectal cancer. I think it's important that to consider that all steps we have been doing in rectal cancers in the last almost 30 years have been to improve on local control. We have developed first a total mesorectal excision as a standard of care for high quality surgery. MRI has been established as local regional staging tool, and also the watch and wait strategy was recently introduced. The key point is that also we have in this year 2 new trials, the Rapido one and the Prodigy 23, indicating that we can also reduce disease-related treatment failure, or we can improve disease-free survival, reducing the risk of metastatic disease in patients with locally advanced rectal cancers. And these 2 trials have been communicated and are about to get published this year. The first one, the Rapido trial, is a randomized trial including a total of 920 patients with MRI-defined locally advanced rectal cancer, in which a standard of care was chemoradiation followed by surgery and optional adjuvant chemotherapy versus a more experimental approach in which patients were receiving short course radiation as first therapy, followed by neoadjuvant Celox or Folfox, followed by surgery in a strategy of total neoadjuvant therapy. The main endpoint was disease-related treatment failure at 3 years, and according to the statistics of the trial and its design, had to be improved from 30, decreased from 30 to 22.5%. It's important to underline that MRI was mandatory in this trial, and patients were selected only if they presented those MRI-defined high-risk features, being extramural vascular invasion, T4, circumferential resection fascia involvement, and also N2 positive tumors. This trial met its primary endpoint, able to reduce disease-related treatment failure from 30 to 23.7%. And this is excellent news for locally advanced rectal cancer patients. The Prodigy 23 has a different design, although standard of care was also a similar type of treatment. So long course chemoradiation with concomitant capecitabine, followed by surgery and adjuvant chemotherapy, oxaliplatin based. While in the experimental arm, all patients started with intensive modified FOLFIRINOX schedule, followed by long course chemoradiation, and then surgery and potentially adjuvant chemotherapy. Disease-free survival was the primary endpoint of this trial, and had to be improved by 10% at 3 years. Those are the main characteristics of patients included in both trials. As I told you before, Rapido was including more patients, and the selection was for higher risk patients. In fact, we have a 30% T4 tumors in the Rapido, while in the Prodigy 23, only 15-17% of them were staged as T4. 2/3 of patients in the Rapido were clinically staged as N2, and extramural vascular invasion, which is a very good predictor of metastatic disease, was also present in almost 1/3 of the Rapido patients, and this is not stated in the PRODIGE 23. Another important fact is that mesorectal fascia involvement was observed in almost 2/3 of patients in the Rapido and only 27% in the PRODIGE 23, indicating that patients in the PRODIGE 23 had less advanced disease. However, when we discuss the outcomes of this trial, both trials are positive. There is a decrease of disease-related treatment failure in 6.7% for the Rapido trial, about 7% improvement in disease-free survival in the PRODIGE 23, both statistically significant, with a 3-year metastasis-free survival improved for the experimental arm of both trials, and very importantly, pathological complete remission rate was almost doubled in both trials, indicating that pre-operative chemotherapy before or after radiation is going to increase this pathological complete remission rate, which is very important, provided the opportunity of watch and wait for advanced rectal cancer patients. No data in survival are significantly different because it's too early to assess this endpoint. Concerning anal cancer, this year, 2020, is very special because we have, for the first time, a randomized clinical trial coming from an international effort in patients with advanced or metastatic anal cancer. And it was recently published in the Journal of Clinical Oncology. It's only a phase 2 randomized trial comparing carboplatin and paclitaxel versus cisplatin fluorouracil, a very conventional way of treating these tumors. And results are interesting because despite response rate is similar and reaches 59-57% for these two different type of schedules, and PFS is really not different for these different type of treatments. However, overall survival favors slightly carboplatin and paclitaxel with no signs of worse toxicity, indicating a stronger standard of care for patients with advanced anal cancer. I would like to thank you for your kind attention, and again to OncoAlert for giving me this opportunity.
Hello, and it's a pleasure to be able to discuss the therapeutic evolution of gastric and esophageal cancer, particularly where we are in 2020 with this disease. My name is Yelena Janjigian. I'm a medical oncologist and associate professor and chief of GI oncology service at Memorial Sloan Kettering in New York. This is my Twitter handle. You can follow me on Twitter at yjanjigianmd. Here are my disclosures. And the summary of today's discussion will focus on the recent studies, particularly in immunotherapy and HER2-directed therapy, giving you a forecast of how this practice will change and evolve over the next year. Particularly looking ahead, what is the role of combination of anti-PD-1 based combination therapies together with HER2 and pembrolizumab or nivolumab? And review of molecular features that affect response and inform treatment decisions and selection of timing. Prior to 2020, and 2020 was a big year for our disease. There were 4 practice-changing studies. Prior to 2020, particularly for adenocarcinoma, nivolumab has been used and approved in Asia, irrespective of PD-L1 status, in later lines of therapy. with third line or beyond. Pembrolizumab is also approved and used in the United States in third line or beyond, but mostly for CPS greater or equal to 1 category or MSI high patients. Although we have a TMB indication as well, most patients in gastric cancer that have high TMB expression also have MSI high tumors. There's minimal benefit for anti-PD-1 therapy in PD-L1 negative patients. 2020 practice-changing studies, where are we with it currently? KEYNOTE-62 is a negative phase 3 randomized trial that was reported in JAMA Oncology recently. And in this study, when pembrolizumab was compared directly to chemotherapy, the hazard ratio for survival was 0.91, which was technically non-inferior, but not clinically applicable. And this was not a practice-changing study because, as you can see here, the survival curves cross in favor of chemotherapy for as long as 12 months. So it's very dangerous for a person potentially to have a progression of disease and pass away from their disease. If they do benefit, the plateau on the curve is quite nice, and there is long-term survivors, but that risk of progression and death is higher for a chemotherapy-sensitive disease. What's interesting also, because it was a smaller underpowered study, comparison of chemotherapy plus immunotherapy with pembrolizumab versus chemotherapy alone was also negative. And the only population where there's maybe a glimmer of hope is in high PD-L1 expressors with CPS greater than 10, and those patients may have a unique biology, but nonetheless, this was a negative, not practice-changing study. And then this year, Checkmate 649 read out, and we're excited to see this data for a combination of FOLFOX chemotherapy with nivolumab or chemotherapy alone. The Nivo-IPI arm was also enrolled, but that data is not yet reported and not ready for prime time. Key eligibility criteria that I want you to be aware of is this was an esophageal adenocarcinoma, G junction, and gastric cancer population. So first study in metastatic setting that enrolled based on histology and the biology as opposed to tumor location. Primary endpoint was OS and PFS, co-primary endpoint, but this was a large study, over 780 patients treated per group, irrespective of PD-L1 status. That's another important point. Patients were enrolled irrespective of PD-L1 status, but the primary endpoint was in PD-L1 CPS greater to equal than 5 population. And the primary endpoint for the study was met across the board. The median OS of 14.4 months is benchmark and groundbreaking for HER2 negative disease to surpass a 1-year survival mark. Is very satisfying. And there's at 12 months, 57% of patients are alive with hazard ratio for survival in CPS greater or equal to 5 category of 0.71, which is both clinically and statistically meaningful. The primary and then the next cut of the data was to examine CPS greater or equal to 1. And in that population, the hazard ratio of 0.77 is also clinically and statistically potentially meaningful. And as you see in all randomized and intent to treat populations, so including patients with PD-L1 negative tumors, the hazard ratio is expected is not as meaningful. It's 0.8, but maybe an important biomarker nonetheless. Median overall survival of 13.8 months, important change, difference nonetheless. And overall, there appears to be, because of the size of the study, a positive intent to treat population as well. This is the overall survival by subgroup. What I want you to take away from this forest plot is how well the MSI high patients do. Again, small population, it's a rare subset, but very important to test for MSI in your patient population. This is where you really can make a difference. Hazard ratio for survival is 0.33. And again, highlights the importance of knowing the biomarker. And in those patients, chemotherapy may not be needed in a combination with immunotherapy, and perhaps immune checkpoint inhibitors is enough. We'll talk a little bit about it in a minute. What are the key differences between KEYNOTE-62 versus Checkmate 649? It's a large patient population for Checkmate 649, 790 patients per group. The median follow-up is shorter, but that data will mature. And again, for subgroup analysis may be important, looking at PFS and overall response rate. Chemo backbone is something that you and I like to use in the clinic for GI malignancies, FOLFOX, as opposed to high-dose cisplatin. And what's interesting is, and also still a moving target, is PD-L1 testing on Checkmate 649 was done with a different antibody. And even though the patients were not enriched for PD-L1 positivity and were enrolled irrespective of PD-L1 status, it appears to be that the rate of PD-L1 CPS greater than 5 and CPS greater than 1 category is a little higher, or maybe a lot higher than what we would expect. For CPS 5, some data suggests that typically, with other antibodies, 30% of the patients are positive, where we saw 60%. So, so this gives us a pause as how reliable a CPS cutoffs are. And really looking at these slides, CPS, to be able to tell the difference between CPS 2, 3, 4, or 5 sometimes is very difficult and quite subjective. And so there's a lot of variation. And this will be the crux of our discussion and problem if the regulatory authorities mandate certain cutoffs for approval. These are the list of different antibodies that are commonly used. And I encourage you to enter into a discussion with your pathologist to find out what are the antibodies that are being used. 28-8 is what was used in Checkmate 649. 22C3 is what commonly is used because of pembrolizumab label. What the exciting data from the Cancer Genome Atlas points out that MSI and EBV tumors are the most immunogenic and have stage for stage the best outcome. How do we improve on that further? Well, this is a case I wanted to share with you, an MSI high patient who presented to see me after progression of disease on on chemotherapy and radiation therapy for localized curable disease. She progressed right through it, went from being stage 2 to stage 4 cancer, and unfortunately progressed further on additional therapy with FOLFOX. What do we do for that patient typically? Well, this patient went on a clinical trial, received an immune checkpoint inhibitor, and responded and had a complete response with nivolumab. In fact, perforated because she had a complete response in the primary tumor. This patient was done a disservice by given chemotherapy. Granted, it was 7 years ago. We didn't know all the data about MSI cancers, but now we do, and we can make a difference. Patients from the MAGIC study, when you test them, and looking at this data by Lizzie Smith and colleagues, shows that if you have an MSI cancer patient and you give them pre-op chemotherapy, you can hurt them because epirubicin-based therapy obviously is toxic and may suppress immunotherapy, the immune response that the body is mounting against the cancer. In gold here, it shows 9.6 median OS for MSI high tumors that got chemotherapy. And in gray, the median survival for MSI tumors that did not get chemotherapy and just had surgery was not even reached, suggesting how well they do if we just leave them alone. But we can definitely improve on the surgery alone with chemotherapy, with the immunotherapy and not chemotherapy. Keynote 62 data again showed that a hazard ratio for survival for a pembrolizumab treated arm is 0.29 compared to chemotherapy arm, and 0.37 for pembrolizumab plus chemotherapy, similar to what we saw in Checkmate 649. So critical in first-line stage 4 cases to know and treat with pembrolizumab. But my point is that it's also very important to do it in earlier stage 2 or 3 cancers before surgery and may have potentially avoid chemotherapy. This is a trial we're doing to address adjuvant pembrolizumab question based on circulating tumor DNA and to look for clearance of ctDNA. And so patients only with ctDNA positive tumors after surgery are then treated with pembrolizumab. Checkmate 577 study looked at adjuvant nivolumab, and what really we found is that irrespective of histology, adenocarcinoma or squamous, when compared to placebo in high-risk population with node positive or persistent tumor in the primary tumor despite chemoradiation with a cross regimen. As you can see here, this was a 532 patient arm with nivolumab, so a relatively big neoadjuvant or adjuvant rather study. The disease-free survival was clearly highlighting the importance of nivolumab in that population. Doubling of DFS, 22 months versus 11 months. So this is I think, practice changing, and we need to wait for the OS data. But at this point, I would act on DFS data, as it is already highlighting the importance of adjuvant therapy in this population. And these patients recur and die of their disease, so we need to act and not wait for any other OS data for now. HER2 in esophageal and gastric cancer has been a passion and a research target of many of us. It occurs in 20 to 30% of the population. Trastuzumab has changed the practice in 2009, and since then there's been a lull. And the reason why there were all these negative studies is HER2 is not that straightforward in gastric cancer. First of all, there's quite a bit of heterogeneity, and the difference of HER2 expression, the level matters particularly in gastric, because we do have a lot of RAS and RTK activation with EGFR and MET co-amplification, which is different than the breast cancer. So if you have a high HER2 overexpressing tumor, IHC3+ or FISH2+ and FISH positive, IHC2 plus FISH positive, as shown here with the TOGA regimen, your OS is 16 months, as opposed to if you have all comers, which was the intent to treat population with the TOGA shown on the left. We showed that if you have a ctDNA or tumor amplification, in this graph we're looking at tumor amplification by ERBB2, and if you have a very high expression, high quartile, and if you have a RAS wild type tumor without any co-amplifications in EGFR or MET, those patients benefit the most from trastuzumab with very durable PFS. And then gradations going down if you have a low ERBB2 amplification where it's not even picked up by NGS, patients do poorly. But if you have a high ERBB2 amplification with co-occurring RAS or PI3 kinase alterations or other RTK activation, you fall somewhere in between. So how do we help these patients? How do we help the patients who are on the green, blue, and red curve? Well, we augment their response with immune checkpoint inhibitors. And this is a trial that we did, a phase 2 trial, which is now published again this year, looking at a combination of pembrolizumab, trastuzumab with chemotherapy. And we found a 91% overall response rate compared to 47%, which was seen in the historic data with TOGA. Why do we see it? It goes back to HER2. What we do is we amplify the ADC effect that trastuzumab carries, and pembrolizumab further amplifies this. We need to confirm this data, and the phase 3 study is nearly complete and will be completed in 2021. So hopefully we'll get a new target and new approval for the HER2 study, for HER2 population as well. Here again, ctDNA is predictive. If you have high level of ERBB2 amplification in the ctDNA, you tend to do better, and it's more durable, the response. And perhaps there is a way that we can cure these patients. And I can tell you several of my patients on the study, the complete response rate was 17%, so 6 patients. And some of them went on to have curative resection and alive and well for several years now. So we're changing the paradigm and selecting patients that may be cured even with metastatic disease in HER2 positive setting. Destiny Gastric 01 looked at treatment refractory population where it's really difficult to target HER2, and many trials have been negative, and so we're starting to lose hope. And so this gastric destiny study was very exciting when it's read out, particularly for the primary cohort. So the primary cohort looked at patients with in third-line setting that were historically HER2 positive. In other words, most of them were not rebiopsied at the time of trastuzumab progression. They progressed on trastuzumab and ramucirumab-based therapy and received T-DXd or investigator's choice chemotherapy, which was usually taxane or irinotecan. The overall response rate in 119 patients, which is a relatively large study, confirmed overall response rate was 42%, which is believable and very promising in this setting, very exciting, believable and exciting. So what about the lower HER2 expressors? IHC2+, this was an update at ESMO that showed 26% overall response rate. Tiny number, only 19 patients treated. and I'm not saying rush out and start treating HER2 negative patients with this agent, but what it gives us is reassurance that if you have a lot of heterogeneity within the tumor or within the different metastases, perhaps your patient will still benefit from this drug in later lines of therapy. And certainly the overall response rate is promising in this population with HER2 positive cases. And this is, again, the primary cohort, the OS and PFS. You know, was a Japanese study, so those patients tend to do better. We have to take it with a grain of salt. And we are doing confirmatory studies in the US and Europe. But look at this, 12 months overall survival of 52%. It's just amazing. And Shitara and colleagues published this in New England Journal of Medicine. And this will likely lead to approval in third-line setting in the US because we don't have anything else to offer these patients. And this is, again, the waterfall for the lower expressors. IHC1 plus, not all that promising, but 2 plus FISH negative, it's you know, there's some grain of interesting data there. So, you know, where we are with gastric cancer, it's very exciting. 2020 was a very productive year, despite all the heartbreak and setbacks in the world. So FOLFOX nivolumab is likely to replace standard of care. Adjuvant nivolumab DFS benefit irrespective of PD-L1 status and histology. Please order HER2, MSI, and PD-L1, as well as EBV on all your patients. And look out for new targeted therapies for in third-line setting for HER2-positive disease, particularly trastuzumab deruxtecan, but there are also others under development. And I thank you for your attention and have a great day. Bye-bye.
Hello, my name is Mark Lewis. I am a medical oncologist. I'm the director of gastrointestinal oncology at Intermountain Healthcare in Salt Lake City in Utah in the United States. And I'm always privileged to be a member of OncoAlert, but on this particular occasion, I feel very fortunate that our fearless leader, Dr. Gil Morgan, asked me to speak on the pancreas. Gil knows this is an organ that is near and dear to my heart, partly because I have only half of mine. In 2017, I underwent a Whipple procedure to remove a malignant neuroendocrine tumor from the head of my pancreas in the setting of MEN1 syndrome. And so almost selfishly, I like to keep up with developments related to this organ. That said, and on a less selfish note, a lot of my professional practice is dedicated to the care of patients affected by both exocrine and endocrine tumors of the pancreas. And it does gladden my heart to share with you that even in this year, we've heard of advances in the field that can benefit both of those patient groups. So I'm just going to quickly walk through slides, largely culled from meetings and articles that have taken place this year or been published this year, and also some social media commentary as well, including from some of our other OncoAlert members. So the agenda here, I do want to talk a lot about PDAC. So pancreatic ductal adenocarcinoma probably has had the most shift in management this year. There's an increasing role for germline testing that we need to discuss. I think we need to then understand the therapeutic implications of finding a DNA damage repair defect in a patient. We need to reconsider a therapeutic sequence. I don't think we're quite yet to the point of total neoadjuvant therapy, but we'll talk about the rationale of induction type schemas before operations for even upfront resectable pancreatic ductal adenocarcinoma. And then finally, I have to sneak this in, there has been, I think, a fairly major advance in the treatment of pancreatic neuroendocrine tumors that also, I think, merits discussion. So let's start by pointing out that we should not allow ourselves to assume an attitude of therapeutic nihilism when it comes to treating pancreatic ductal adenocarcinoma or even considering the genomics of this disease. I think a lot of us have gotten used to fairly bland findings when we sequence PDAC. It tends to be a fairly rote number of mutations that you'll find, KRAS, SMAD4, P53, often unfortunately not terribly actionable. However, you don't find what you don't look for, and increasingly we're seeing that there is a small but substantive minority of patients that really do have meaningful mutations if you find them. And really what we're getting at here is we should be considering the germline and not just the somatic context. And so this is a little bit of a glimpse in the future. This is the NCCN guidelines from February of 2021. What I want you to see here is the NCCN, to their credit, is really being quite definitive now in recommending genetic counseling and germline testing for all individuals diagnosed with exocrine pancreatic cancer and their first-degree relatives. And here, to those of us that are privileged enough to have access to genetic counseling, I would really encourage oncologists, as much as we want to assume primacy and control, to really use our GCs as a resource, because this is increasingly complex. It's not just about BRCA-ness, as you'll see here. The NCCN highlights ATM, along with the BRCA mutations. CDKN2A, of course, is also seen in familial melanoma. Most of the Lynch genes that we're familiar with, MLH1, MSH2, MSH6, and EpCAM. PALB2, and that's going to get special attention in a study we'll discuss in just a few slides by Dr. O'Reilly and colleagues, and then STK11 and P53 in the setting of leaf-run-many. I'll also point out, as long as we're trying to steer away from nihilism, this is not a moot point even in stage 4 disease. And so the NCCN also, in the same set of guidelines, recommends germline testing and gene profiling of the tumor as clinically indicated, ideally, in the latter case, using a metastatic biopsy site. Okay, so now I went, seems like a world away. This was the last conference I attended in person. This was ASCO GI in January of this year in San Francisco. We received these results. And this was interesting because this trial was obviously conducted and maturing while and after the POLO trial was announced at last year's ASCO annual meeting. And I think here we were really testing the biological plausibility of PARP inhibition in pancreatic ductal adenocarcinoma with specific DNA damage repair defects. And in this particular case, we were looking at germline BRCA and PALB2 mutations. So Dr. O'Reilly and colleagues presented these data at ASCO GI with simultaneous e-publication in JCO. And this was a randomized phase 2 study of GemCis plus or minus veliparib in PDAC with those mutations. Arm A was the GemCis doublet, and Arm B was GemCis plus the PARP inhibitor. The primary endpoint was response rate. And what's interesting is you see there, actually there was no meaningful difference in response between the two arms. And if anything, it seemed to be slightly higher in the GemCis doublet without the PARP inhibitor. You can see the waterfall plot there. Arms A and B both were achieving fairly significant response. Median PFS was no different between the arms, 10 months roughly in both. And median overall survival also wasn't significantly different between 15 and 16 months, depending on the arm. However, I think what's important here is I wouldn't call them exceptional responders, but there's a group here who then end up surviving longer than you might think. So in the entire cohort, so both arms combined, the 2-year overall survival was right around 30%, and the 3-year overall survival was almost 18%. And I realize those are still pretty bleak compared to some of the other tumors we deal with. But in pancreatic ductal adenocarcinoma, I think it's really important we don't miss these people, because really what I think this did was, I think these data establish gemcitabine and cisplatin as really a standard approach in PDAC that's germline mutant in this manner. Another OncoAlert member who's quite prolific, especially in the liquid biopsy space, is Pashtun Qazi. I want to credit him for pointing out that DNA damage repair defects are not all created equal, and again, they're not all about BRCA-ness. And so the schema on the left there shows you that when a double-strand break occurs, the process of homologous recombination repair can involve a lot of different proteins. In fact, this isn't even an exhaustive list. And so the work that Pashtun presented was very interesting. So this was work out of Mayo, where he was a fellow. And what they were looking at was the clinical characteristics and overall survival of germline mutation carriers in HRR, so homologous recombination repair, and non-carriers of those mutations in patients with PDAC. And so this looked at over 3,000 patients at Mayo over 17-year intervals, so 2000 and 2017, so plenty of times for survival data to mature. And they analyzed for 37 cancer predisposition genes and then picked out 8 of them involved in HRR around PDAC. And those were ATM, BARD1, BRCAs, BRIP1, PALB2, and then RAD51C and RAD51D. And so what they found is, of all the patients they tested, there was 175 carriers and then 2,730 non-carriers, a median duration of follow-up of nearly a decade. What was interesting, and perhaps not surprising, is that the HRR mutation carriers were younger at diagnosis, so a median age of 63 versus 66 years. They were more likely to have metastatic disease. However, in a multivariate model that accounted for age, sex, and tumor staging, the patients with the germline HRR mutations were significantly longer survivors. So their OS really was superior, with a hazard ratio that did not cross 1. And then further gene level analysis showed that germline ATM mutants actually did the best, with a hazard ratio of 0.72, compared with patients who had no mutations in any of the cancer susceptibility genes. So some of the sort of postulates that came out of this are, again, maybe the patients that carry these mutations are better responders to platinum. And again, I think the O'Reilly data have shown that. However, there's also a theory that irinotecan containing regimens, whether FOLFIRINOX or FOLFIRI itself, may also work particularly well in this space, because maybe these mutants are particularly vulnerable to the therapeutic action of topoisomerase inhibition. So I think there's a lot of work to be done there. Again, I think this is a growing subset of PDAC in terms of its recognition. And I think it's really, really important because it has profound therapeutic implications for these patients. The other thing I'll point out, and I don't know how many of you feel the same, but one of the most heartbreaking questions I get asked in my oncology clinic, particularly at the initial consultation, is, "Doctor, why me?" And I think we've done a lot of work in terms of removing stigma from a cancer diagnosis, but I also think we have miles to go before we sleep. And so often I will actually invoke, because I think it is so encompassing, this formula presented by our poet laureate of oncology, Dr. Sid Mukherjee, in his book, The Gene. He basically spells out that all the things that happen to us, including oncogenesis, boil down to genotype, environment, triggers, and chance. Now that last one is really hard for some people to accept. It's essentially the slings and arrows of outrageous fortune. But it also, I think, is proof positive that our patients absolutely do not deserve their diseases, and frankly may have done absolutely nothing wrong to be the victims of sort of stochastic events for their cancers to arise. However, what I'm really drilling down at here is that first part of the formula, genotype, I think is so important. And here I have to almost recuse myself from bias, because I come from an NEN1 kindred, and I'm the proband in my family. I'm the first person to actually recognize and have a formal diagnosis of an autosomal dominant tumor syndrome. And so I've seen in my own life, and now try to apply to my own practice, the importance of identifying the proband. Imagine, for instance, finding a BRCA positive PDAC patient. That has implications not just for the patient, but for their kindred. And those people can then be screened, not just for pancreas cancer, but potentially even take prophylactic maneuvers against breast and ovarian cancer in women. Angelina Jolie being, I think, the most famous example of that. So again, it's not just about the patient sitting in front of you. It's about, are they an index case for their entire family? So one of the, I think, great debates and arguably areas of improvement in pancreatic cancer in recent years has been around sequencing of therapy. And I'll say a couple things about this. Again, I went through a Whipple for a neuroendocrine tumor, so I really do not have any leg to stand on when it's talking about PDAC. I've not had chemotherapy. However, I vividly remember, because I had a fairly protracted recovery from my surgery, thinking, I don't know if I could receive adjuvant chemotherapy in a timely window, even if it was indicated. And I certainly don't think I could have stomached a triplet like FOLFIRINOX. I also think it's really important to select out the patients who are truly and durably going to benefit from an operation of that magnitude. I think one of the worst things we can do to someone is perform a Whipple, and then even in that space where they're still recovering from the surgery and before chemotherapy has been initiated, we sometimes see a blossom of liver metastases. And then you realize that the biology trumps the operation, and that person probably shouldn't have undergone the surgery in the first place, even if they were deemed resectable. Okay, so getting off my soapbox a little bit. the data I'm showing you here were presented at ASCO 2018, and I really think that was a landmark conference for pancreatic cancer management. Arguably, FOLFIRINOX got snubbed at plenary after showing really unheard of long-term survival when used in the adjuvant setting for PDAC. Clearly, I'm not still bitter about that. But I think the other sort of seminal work that was presented there was this, the pre-OPANC data. And again, maybe many of us would not duplicate this exact schema in terms of upfront treatment, but I think it's the proof of principle here that really matters. So again, this is 2018 data, not 2020 data, but I think it really has allowed us to think about and rationalize being very, very deliberate with preoperative treatment in pancreatic cancer, even if we deem it to be resectable up front, with consultation, of course, with an expert HPV surgeon. So what they did in pre-OPANC is they randomized patients to either go straight to surgery or to receive upfront sort of a GEM sandwich before surgery. And again, many of us would not choose that particular approach, but here's what they found. There was actually fewer patients ended up having resection in the latter group who had preoperative radiochemotherapy. However, the rate of R0 resection doubled. And so, again, this is a disease where if you're going to take a big swing and do, say, the Whipple surgery, you really want to make sure that that's as complete an operation as possible. And so I think, again, picking the patients that are better operative candidates and are more likely to have the optimal surgical outcome is really, really important. So I'm not fond of the phrase statistically insignificant and clinically meaningful. Sometimes that's just sophistry. However, I'll point out here that when you look at the group that received radiochemotherapy followed by an XLAP, as opposed to people that just had the XLAP up front, you do start to get a hint of a survival benefit. And then really sort of cherry picking here, if you look at the patients who underwent R0 or even R1 resection, I think there was a pretty significant shift in survival towards improvement if you had that radiochemotherapy up front. And again, the median OS of 42 months there is getting into Protégé 24 territory. Okay, so what about this year? So S1505 is a trial we've been awaiting a long time out of the SWOG Cancer Research Network. And I've got two people to thank for this slide. One is Dr. Sohal, the presenter of this data, and number two is Dr. Shalon Beg, who made this visual abstract, and I think they did a really beautiful job. So as Shalon sums up in the top left there, sort of the rationale for neoadjuvant or induction chemotherapy before resection of a pancreatic cancer or an adenocarcinoma is to treat micrometastatic disease, increase the rate of chemotherapy delivery, and I think this is really important, prevent futile surgery in aggressive disease. So the schema here, I think, was pretty clever, and again, had some surprising and maybe even some counterintuitive results that we'll discuss. So the patients were randomized to receive either FOLFIRINOX for 3 months preoperatively or GEM nab-paclitaxel for 3 months preoperatively. And then they were restaged to make sure there was no progressive disease. Then ideally they underwent resection, and then they were supposed to receive another 3 months of the same regimen postoperatively. So of 147 patients who enrolled, a full 44 of them were actually deemed ineligible or unresectable by radiographic criteria, which left 102 patients for the final efficacy analysis, 55 of whom got FOLFIRINOX and 47 of whom got GEM Abraxane. Preoperative chemo is completed by exactly the same number in each arm, so 85% in both. And a total of 55% of patients got to adjuvant. And again, that's important. I think we've seen that in other trials, like say FLOT4 in Gastric, where maybe only about half of people roughly get to the post-op part. So I think a lot of the work is actually being done on the preoperative side of treatment. So the primary endpoint here, if I move my camera, was 2-year overall survival. So interestingly, there was no significant difference between the triplet or doublet approach, nor was there a meaningful difference in R0 resection. Pathologic response, curiously, actually trended towards being higher with the doublet, and there was no meaningful difference in DFS. So again, this is one of those cases where you cannot fit your laser pointer comfortably between the curves. I'll also point out that the target of a 58% 2-year survival was not met in either arm. And then I had nothing substantive to add to the debate around ASCO, so I just generated a meme where you can see the medical oncologists there sweating as they now try to decide how to approach induction chemotherapy in this setting, and I think it remains to be seen. One thing that I'm excited about, and this is, I think, going to mature early in 2021 in terms of when we get the data, hopefully at ASCO GI, this is a trial we've been waiting for some time, run by Dr. Matthew Katz, an HPP surgeon at MD Anderson through the Alliance. This is A021501. This is really interesting in that it looks at extended chemo, so FOLFIRINOX times 8, or chemo plus hypofractionated radiation, so FOLFIRINOX times 7, followed by XRT for borderline resectable adenocarcinoma of the head of the pancreas. They hit their accrual target in May of last year, and again, I think we'll get the results upcoming at ASCO GI. I'll point out this slide, if I haven't made it explicit already, I will now. The management of pancreatic cancer is increasingly so multidisciplinary that I really don't think medical oncologists should be operating in a vacuum, particularly when it comes to judging operability. And I really think that's not even just a one-time decision at the beginning. I think it's iterative and really needs to be brought up at almost every restaging. So again, I'm very fortunate at my institution to have a tumor board every week where radiation oncology, medical oncology, and surgical oncology discuss these cases in some detail. And I've learned not to be too judgmental about who I think is operable. Certainly, I think borderline resectability has obviously some pretty strict criteria, but also some willingness of the surgeons to consider some vascular revision, particularly in the peripancreatic vessels. Okay, now we're going to turn to my type of tumor, which is the NETs. And I just wanted to say the past is prologue, and this is a slide I've borrowed from Dr. Matthew Kulke, a specialist in the field. I think it's kind of remarkable if you look at the, at first compressed and now sort of elasticized timeline there at the top. So this is not necessarily a linear scale, to see just how much progress has been made in NETs, especially in the last decade. So I vividly remember the day in 2011, I was a fellow at the time. I saw some of my otherwise very conservative faculty at the Mayo Clinic high-fiving with the dual publication of sunitinib and everolimus data in the New England Journal, I believe February of that year for peanuts. And since then, the indication for everolimus has broadened with Radiant-4. We have teletristat now, which is very helpful with carcinoid syndrome, diarrhea in particular, and Lutathera. And there, I do have to give appropriate kudos to our European OncoAlert members. Your continent has done so much for peptide receptor radionuclide therapy, particularly centers like Bad Berka and Rotterdam have literally been decades ahead of the United States, and your work has now rendered lutetium-based therapy both approved and accessible to us. So thank you so much for laying the groundwork. Interestingly, this slide is now out of date because we have, I think, a new drug that we should discuss. So Cervantes is a pretty fascinating small molecule inhibitor, and we've known for some time that neuroendocrine tumors are extremely hypervascular. You can see that particularly in some of the liver imaging when there's hepatic metastases. And thus, it's biologically plausible and quite seductive to think that they are amenable to anti-angiogenesis, and there's certainly been signal there with sunitinib. So surufatinib is a small molecule inhibitor of VEGF receptor 1, 2, and 3, FGFR1, and then CSF R1 as well. And so I think it's largely the anti-VEGF activity that is probably doing the heavy lifting here. This was a fascinating study, SANET-P, just published in The Lancet. This was a randomized, double-blind, placebo-controlled trial where there was 2-to-1 randomization to drug versus placebo. The PNET patients had to have had progression on no more than 2 prior lines of therapy. And then the primary endpoint was median progression-free survival. And you can see here these curves. This is a meaningful, separation. For the placebo arm, the PFS was, I believe, 3.9 months, 3.7, excuse me. And then for the surufatinib arm, it was 10.9 months. So I think this is really an exciting drug to have in the armamentarium. It's not yet readily available in the United States. It's been designated orphan drug status by the FDA, and we're currently hoping to get our hands on it very, very soon. But I do think it's an important step forward in PNET management. So with that, I will close. I just wanted to say to all of you, I hope the colloquium is helpful in staying up to date during this crazy, crazy year. But even more importantly, I just wanted to tell you what a sense of community I feel online on Med Twitter and in OncoAlert specifically. So thank you so much. Wherever this finds you, I hope you're happy, healthy, and stay safe.
Hello, everyone. Many thanks to OncoAlert and the sponsors of the first online OncoAlert Colloquium for inviting me to share the patient perspective in this session. I'm Dr. Manju George, a stage 3B rectal cancer survivor. I'm also the scientific director of ColonTown. I'm a patient advocate at the NCI Rectal Anal Task Force and the Stand Up to Cancer CRC Dream Team. ColonTown is an online international colorectal cancer patient and caregiver support and education community. We believe in patient empowerment through education. In ColonTown, we have over 140 different neighborhoods that cater to almost every aspect of the CRC patient and caregiver experience. This includes our clinical trial groups, where information about promising clinical trials are posted on a regular basis. My talk is titled 2020 from a CRC patient point of view. First, let us remind ourselves why we are here. Colorectal cancer is the second leading cause of cancer-related mortality in men and women combined in the US. We expect 104,610 new CRC cases this year, of which 17,930 will be of rectal cancer. We expect 53,200 deaths from CRC, of which 3,640 are deaths in patients under the age of 50. One among them, Chadwick Boseman, recently brought the spotlight on the rising incidence of CRC in young people. So I want to take a moment to, in memory of all the lives we have lost, and also to thank, the healthcare workers, oncologists, surgeons, radiation oncologists, GI doctors, nurses, and all the support staff for everything that you've done, that you do on a regular basis to save and extend the lives of people affected by colorectal cancer. First on my list today is this, which is the lowering of CRC screening age. Recently, USPSTF issued draft guidelines to reduce the CRC screening age from 50 to 45. In my mind, this is the most or the single significant development from 2020, which when finalized has the potential to save a lot of lives from colorectal cancer. The second item on my list is the results of the IDEA CRC trial, which is less is more for the duration of adjuvant chemotherapy. The results from this trial was presented at ASCO earlier this year, and the take-home message is that for the vast majority of stage 3 colorectal cancer patients, 3 months of adjuvant chemo, that is about 4 cycles of K-Pox, is recommended. What does it mean for patients? It means that patients have a more proactive role and are part of the collaborative decision-making with their care team to find the duration of adjuvant chemotherapy that fits their tumor and needs. It also means that for patients with the shorter duration of adjuvant chemotherapy, there are lower chances of long-term neuropathy. What we also find among patient groups is an increased awareness and interest in tests that differentiate high-risk versus low-risk tumors. For example, immunoscore, ctDNA, liquid biopsy, etc. The third item in my list is ctDNA tests for minimal residual disease. Dr. John Marshall called ctDNA tumor trash in your bloodstream. It looks like in 2020, these ctDNA tests are becoming more mainstream. Here I give an example of Signatera, which is a test for minimal residual disease, and they use a personalized and tumor-informed approach where the tumor is first sequenced to identify a unique signature of tumor mutations, And then based on this, they design a custom assay for each patient, and it targets about up to 16 mutations found in the tumor. And using this personalized assay, they test the patient's blood for the presence of circulating tumor DNA. There is a lot of interest among patients with respect to these tests, and my hope is that in the coming years, MRD testing based on ctDNA becomes standard of care. There are a couple of ongoing trials and many planned to test the utility of ctDNA as a predictive biomarker. The next item in my list is rectal cancer. The trend in 2020 is more towards total neoadjuvant therapy and non-operative management. So for locally advanced rectal cancer, it seems that now therapy has become more personalized. The three different modes of treatment that make up the treatment for rectal cancer, radiotherapy, systemic chemotherapy, and surgery seem more customizable and seems to be able to be more personalized depending on the patient's tumor and preferences where possible. So again, this means that there's a lot of collaborative decision-making between the patient, the care team of radiation oncologists and surgeons. And it seems that the trend is more towards organ preservation. And so there is a lot more focus on quality of life. What patients want now is in order to be effective in collaborative decision making, patients need to be informed, and patient and caregiver support communities like ColonTown can play a big role in educating patients. The other thing, with the increasing rates of rectal cancer, we need a lot more to be done towards side effect management. For example, the bowel, urinary, and sexual dysfunction that can result because of rectal cancer treatment has major implications for quality of life. The last item on my list is the availability of more treatment options. Though this year, COVID has had a lot of ill effects on healthcare and biomedical research. With respect to colorectal cancer, we have had some new improved therapy options possible this year. For example, for MSI high colorectal cancer, which is like about 4% of our metastatic MSI high colorectal cancer, which is about 4% of all stage 4 CRC. Immunotherapy is now approved as first-line therapy. And then the BRAF V600E mutant colorectal cancer is about 10% of all CRC. And at ESMO this year, new results were presented of a trial of targeted therapy plus immunotherapy, which is being run at MGH. And this offers a lot of promise. Variations of this trial is now being run at MD Anderson and UCSF. The other trial that is garnering a lot of discussion in the patient community is the second-line FOLFIRI plus bevacizumab plus onvansertib trial. This is for KRAS mutated MSS CRC patients. Though it seems too early to decide one way or another, looking at all the discussion that is going on in the patient communities, it looks like people are pinning a lot of hope on this trial. With that, thank you so much for listening and happy holidays.
Good day, this is Dr. Maryam Lustberg. I'm Associate Professor of Medicine at The Ohio State University in Columbus, Ohio, USA. And I'm the chair of the MASCC Neurological Complications Working Group and the president-elect of MASCC. Today, I'll be speaking to you about neurological complications of cancer and cancer therapies with a focus on clinically relevant emerging management strategies. The agenda is as follows, with a focus on overview of cancer-related neurological toxicities, then chemotherapy-induced neuropathy, followed by cancer-related cognitive impairment, and a wrap up with a focus on emerging research strategies and solutions. Starting with an overview, a range of neurological complications that patients can experience, and they can stem from cancer itself or from our cancer therapies, and they can present as peripheral toxicities or central toxicities. And These are often interlinked and can coexist. The number of cancer survivors worldwide is growing, with recent estimates at 45 million cancer survivors. Although this is great news, many cancer survivors do face late and lasting medical, emotional, and social challenges, with 25% or more actually reporting poor physical health. And many of them actually experience neurological complications that can present as loss of function, including gait and balance changes, decreased quality of life, employment and financial toxicity as a consequence of these functional impairments. And these neurological complications can actually impact cancer outcomes, limiting the dose intensity and the doses of neurotoxic chemotherapy or other targeted therapies that we can actually give. So what is actually new in 2020 with respect to neurological complications? I will give an overview of the recent ASCO 2020 guideline update on CIPN. I will also update you on the 2020 ESMO ENOS and EANO clinical practice guidelines on neuropathy, and also share with you the latest clinically relevant strategies for cancer-related cognitive impairment. So starting with CIPN, prevalence is high, with over a third of patients reporting symptoms at 6 months since diagnosis. Traditional chemotherapy agents tend to be the most common agents associated with CIPN, including taxanes, platinums, Vencup, bortezomib, and thalidomide. But we're also looking at additional neurotoxicity experienced by a number of other newer targeted therapies, as well as immunotherapies. The biggest risk factor tends to be cumulative dose, as well as overall health, with obesity and diabetes being some of the clinical risk factors. And genetic predisposition is something that there is a large growing body of work looking at different genetic biomarkers as predictors of chemotherapy-induced neuropathy. There are various mechanisms of injury depending on the type of agents being used, these are summarized in this next slide, where many of these traditional chemotherapy agents actually have different molecular targets, and this impacts the type of neurotoxic injury that our patients are actually experiencing. This is a view of inside a neuron and the type of mechanisms that are involved as these neurotoxic agents enter the cell through very specific transporters. And then they are involved in a number of mechanistic pathways that can involve mitochondria, lipid peroxidation, DNA damage, inflammatory signals, apoptosis, and axonal degeneration. So I've talked mostly about the standard chemotherapy agents. I did want to highlight the newer immunotherapy agents and what we know so far about their neurotoxicity risk. And these changes can be peripheral or central damage. They're relatively uncommon, but can certainly happen, and it's important to have it on our differential as we treat patients with immunotherapy. Peripheral neuropathy is reported in about 1% of patients receiving these agents. Other peripheral neuropathies, other peripheral neurotoxicities can include myositis and myasthenia gravis. In terms of central changes, encephalitis, demyelination, and neuro-ophthalmologic changes, and large vessel vasculitis have been reported. overall treatment emergent grade 3 neurotoxicity is much less likely to happen with PD-1, PD-L1 therapy compared to conventional chemotherapies, but it's important for these to be recognized. They tend to be later effects after exposure. And the good news is that they tend to improve after discontinuation of immunotherapy and with high-dose steroids. In terms of what happens when we actually combine these agents with neurotoxic chemotherapy, such as taxanes, our data to date actually show that there does not seem to be an increased risk of more frequent or more intense treatment emergent grade 3 or 4 peripheral neuropathies, which is, again, good news. So in terms of gaps in knowledge, these include in the area of prevention of CIPN, treatment of CIPN, biomarkers, as well as patient experience. So the ASCO 2020 guideline, as well as the ESMO 2020 clinical practice guidelines, looked at the latest evidence in the clinical management of CIPN. Starting with prevention, it's important to evaluate the risks and benefits of any cancer treatment that we, of course, deliver. And with respect to CIPN, certainly patients with pre-existing neuropathy or who are at very high risk of neuropathy, this does require informed decision-making and good explanation of what exactly neuropathy is and what the risks are. In terms of number 2, it's to discourage harmful supplements where we may have no data or where we actually have good level of data that they could actually be harmful. And that includes acetyl L-carnitine, which was actually shown to worsen neuropathy outcomes. And then outside of a clinical trial, although there are a number of exciting options that are being explored, including non-pharmacological options such as acupuncture and cryotherapy and cryocompression and exercise, I think it's important to still highlight as a scientific community, as well as to our patients, that the level of evidence for these is still in development and that we cannot make a formal recommendation outside of a clinical trial. In terms of the ESMO clinical practice guidelines and prevention, they echoed many of the ASCO guidelines, highlighting that many of our studies are unfortunately level 2 level of evidence with these smaller randomized trials. And for many of our therapeutic and prevention strategies, we have insufficient evidence of efficacy. And sometimes the evidence actually points toward harm. So with regard to prevention, ESMO was in agreement that there's really no role for a non-pharmacologic intervention that can be recommended at this time, and acknowledge the limitations of data for the non-pharmacologic interventions that you can see listed here. In terms of treatment, there was additional emphasis in the updated guidelines on dose delays, reduction, or termination of therapy in patients who have very symptomatic neuropathy or functional impairment. This cannot be emphasized enough, that this is part of that open communication and to really act on the symptoms that our patients are telling us. Duloxetine has the strongest level of evidence for treatment of CIPN. Again, outside of a clinical trials, although a number of both pharmacologic and non-pharmacologic options are being considered, including acupuncture, exercise, different topicals, outside of a clinical trial, there is insufficient evidence to recommend these at this time. ESMO clinical practice guidelines were very similar with this regard, again highlighting the strength of the data for duloxetine, and further highlighting that the largest phase 3 data that we have for gabapentin for chemotherapy-induced neuropathy was actually a negative study, and hence the recommendation was against use, although we acknowledge that gabapentin is being widely used for other neuropathic conditions, and sometimes this is routinely also prescribed by many practitioners in clinical practice. Similarly, the neurotriptan was a level D recommendation to not use it based on the negative data of a small randomized study. So limited data, but I have included the doses and some of the limitations for your review and knowledge. Topicals are also of interest by many patients and practitioners, and as you can see summarized here, the level of evidence is weaker, except we do have one larger study with over 462 patients with ketamine and amitriptyline topically applied, which actually no benefit was observed. We would say caution with some of these topical therapies due to insufficient level of data, as well as the negative larger study that I have listed for you here. So how do we synthesize and interpret these clinical data within routine clinical practice where patients are coming to see us and they are experiencing chemotherapy-induced neuropathy and our options are so limited? I think it's a dilemma, and I think communication and careful assessment of CIP and symptoms is critical. And also reviewing treatment goals, the intent of treatment, curative versus palliative treatment, the patient's personal goals, and lifestyle can really impact how we synthesize the information about symptoms and toxicities. And ultimately, I think shared decision-making, as we talk about the first two boxes, I think is critical. And this also includes the discussion of the available data as well as the lack of data for some of our options. And I think patients can be informed participants in their care. It's also important to look at other contributors to symptoms of CIPN, including central pathologies and other neuropathies. And as we go forward, I think patient experience needs to be further looked at in terms of how our patient community is actually being impacted by CIPN, and what choices are they making in terms of their day-to-day, and what therapeutic and prevention strategies they're actually using. And so an international MASCC survey is being developed to further understand patient perspectives and to work towards solutions. Moving on to central neurological toxicities, I think the point of the slide is that there may not be as two separate boxes at all, and that, for example, CIPN can directly have effects on the brain and vice versa. And so really, it's important to look at both central and peripheral effects of all our neurological toxicities. Moving on to cancer-related cognitive impairment. Colloquially, this is known as chemo brain, but chemotherapy is not the only cause, and cancer itself, as well as a range of our cancer treatments, can actually cause these cognitive changes, and they can present with problems with memory, concentration, and attention, and can impact a wide range of cancer types. And as you can see, symptoms can persist for months to years after treatment completion, although our long-term data is quite limited. The MASCC Neurological Complication Group recently appraised all the existing data for clinically useful and relevant information which you can peruse in this manuscript, as you can see here. I'll highlight a few treatment-related factors. So as I mentioned, chemotherapy is not the only cause, and targeted therapies, endocrine therapies, stem cell transplantation, as well as immunotherapy can all affect cognition. In addition, patient-related factors such as their overall health and functional status, nutrition, and genetic predisposition, all of these can interlink and cause this syndrome that we call cancer-related cognitive impairment. Although there's no gold standard screening tool, I think it's important to highlight a few easy questions that can be asked during routine clinical practice, including, do you have difficulty paying attention or multitasking, remembering things? Patient-reported outcomes, which hopefully become more and more routine in oncology practices. I think there are several good options in terms of evaluating cognitive issues from the patient's perspective. And then the last two rows highlight more detailed cognitive tools, screening tools that could be used, although they may lack sensitivity. And for patients who are more symptomatic, a formal evaluation by a neuropsychologist with more detailed neuropsychological tests is recommended. And again, it's important to have a wide differential for other contributors, including medication effects, metabolic and endocrine issues, delirium, as well as CNS metastases. So our gaps in knowledge in CRCI are similar to CIPN, with limited options in prevention and treatment. Biomarkers, there are several promising candidates, but certainly not ready for primetime use, and patient experience with the limited data on long-term impact particularly. These are some of the gaps that we're facing. So while we're waiting for additional stronger levels of data, I think how do we manage patients who we're seeing in clinic? And I think patient education is very important. Validating concerns, not dismissing cognitive issues, I think is one of the most important things we can do. And then working collaboratively with our rehab and occupational therapy colleagues to teach adaptive strategies, including organizational aids, and emphasizing good overall health measures and mental health measures such as rest and caring for our mental health. All those things are things that we can readily use in our day-to-day clinics for our patients. In terms of treatment and interventions, I think do we have strongest level of data for these interventions that I've listed here? We do not. I think work is ongoing in this space. But in the meantime, we do have some limited data that cognitive training and rehabilitation may be helpful for some. Exercise may be helpful, but again, data are limited. And mind-body interventions, including meditations, mindfulness, and stress reduction, are some of the things that we can employ judiciously for the right patient who's very symptomatic from these cognitive issues while we're awaiting stronger levels of data. In terms of emerging strategies, I think I've highlighted some of these as I've spoken, but we need, I think, a focus on better communication and shared decision-making, better understanding the biological mechanisms of the injury due to these neurological toxicities, and then designing carefully targeted interventions. And well-designed future studies hopefully will address some of these promising leads that we have with respect to acupuncture, exercise, some of these non-pharmacological options such as cryocompression, and a very, very, very wonderful menu of targeted pharmacological options that are currently being tested in smaller phase studies. And as we design these studies, good and better patient-reported outcome monitoring, better standardization of assessments across studies, and predictive biomarkers for both toxicity assessment as well as which patients benefit more from certain therapies over others. I think this is the future and is already underway. I thank the OncoAlert Colloquium, Gail Morgan, and all of you for listening. Thank you so much.
Hi everyone, my name is Ray Chan. I'm a professor of cancer nursing at Queensland University of Technology, as well as the Princess Alexandra Hospital here in Brisbane, Australia. I'm also the chair for the MASCC survivorship group. And I would like to thank OncoAlert for this opportunity for me to represent MASCC in sharing on the topic that I'm very interested in, which is around financial toxicity. And some of you here would be familiar with the term financial toxicity, but today I would like to focus a little bit to draw some relationship between financial toxicity and supportive care, and hopefully some of the data that I share would be of interest to you. First of all, I'd just like to highlight a very active group of people who are passionate about cancer survivorship and outcomes of cancer survivors. So I'd just like to let people know that we have got this very vibrant, productive group of professionals, researchers, consumers working together to improve outcomes, and to go to the website and check us out, and we would love to join forces with you to improve outcomes for our patients. An overview of the presentation. First of all, I'd just like to give you a little bit of an overview. Then I want to zoom in a little bit to talk to you about, in particular, concerning supportive care. What are the relationships between financial toxicity and symptom outcomes? Because we all know that symptom management forms a big part of supportive care considerations. And finally, with the data that we have to date, what are some of the implications for care? So what is financial toxicity? Financial toxicity is a term in oncology to describe financial distress and hardship arising from either the cancer itself or its treatment. There are multiple other terms to describe financial toxicity, including financial stress, hardship, burden, or economic burden, and these terms are used interchangeably. We know that cancer is one of the most expensive conditions to treat, and people, it could be from any sort of therapies or any settings. Basically, people can experience financial toxicity. Over the past 10 years, we know that with all these treatment advances, it's very likely that the cost and the prices of all these treatments would all pile up as well, and eventually someone has to pay for it, whether it is the users or the system. And we know that financial toxicity is not just experienced by the patient, but also the family as a unit. We did this systematic review a couple of years ago, and we were looking at the very recent literature just to quantify financial toxicity. And what we found were 25 studies, including 271,000 cancer survivors. You can see that there are varying levels of frequencies depending on how you measure it, but it could range from 1 in 3 to 2 in 3 cancer survivors. And regardless of whether you are in a user-pay universal healthcare system or hybrid system, financial toxicity exists. And here are some of the determinants that we found in the literature as we summarize the findings from 25 studies. But what I really want to highlight is that some of these factors can vary depending on the context and the health system that, that the person is in. When we look into the literature over the past 10 years, you can see that there has been a very steep rise. From 2010 to 2020, it is still a relatively emerging and new science in terms of our knowledge of this phenomena. There are varying, I guess, gaps in the literature, with many of them focusing on cross-sectional populations. People do use quite a number of varying tools to describe or measure financial toxicity. And we're still unsure at times whether some of the findings that we get, whether they're really representative of all populations or whether they're actually any selection biases. And of course, whenever we ask people to recall their spending, at times we really suffer from having recall bias as well from participants of surveys. So this is a very, very good conceptual framework put up by Carrera in a CA Cancer Journal for clinicians. And you can see how the causes of financial toxicity, and once again, you can see health insurance here being a big issue in many health systems, not necessarily all health systems, but then it actually have a cascade of actions that would actually activate a number of coping mechanisms and eventually patient outcomes. And when we look at distress, quality of life and health outcomes here, I do think that we need to really, really start thinking, although there are many things around this site whereby we really need healthcare system reform, system level interventions, policy research. Over here, when we actually manage the more distal consequences of financial toxicity, we really can afford to think about how we can actually begin to address these impaired outcomes from a supportive care point of view. In terms of measuring financial toxicity, we know that we can measure how much patients actually pay out of pocket, productivity losses due to treatment or due to their disability, that they have inability to work or reduced workability. And we know we can measure people's debt, distress, and of course, recently there has been a number of composite tools, and one of which is the cost facet tool over here, and I've got the version 1 here, but now it's up to the version 2, and this particular tool is now being made available in a number of languages as well. So measuring and quantifying financial toxicity is important, and we know that there are a number of ways for us to do that. In terms of the effects, it is very important when we think about financial toxicity that we don't just think about it being a problem, but how does it actually affect on our patient outcomes? One of the issues will be around forgone care, and we need to quantify that and monitor them so that we can actually try to either highlight that at a system level or actually try to intervene at patient level. Financial toxicity can cause high distress. From our systematic reviews and our understanding of the literature, we know that financial toxicity is highly correlated to higher levels of distress, poorer levels of quality of life, poorer symptom burden. We have less information or solid evidence around survival, but we know that if patients do have impaired outcomes and forgone care, it is likely that there is a link, but we still need further research to describe that. And of course, carer's burden and the whole family experiencing financial toxicity would have negative effects through a number of ways, and one of which is around employment changes from carrying responsibilities. So it is very helpful for us to start thinking different levels of intervention and how we can begin to make changes in alleviating the impacts of financial toxicity. And I think we can think about it either at a high level system policy level, or actually at the service, at the coal phase, when we are actually with the patients, what we can actually begin to do with them. I began to have this interest, I guess, a few years ago, when I began to actually try to quantify some of these impacts by examining the relationships between financial toxicity and symptom burden. In this particular work, we located 9 included studies. In particular, we wanted to look at symptom burden. So we found 9 studies, including around 11,000 cancer survivors. Most of them were of high quality. It was very interesting that the current state of literature can give us a very clear relationship, positive relationship between high levels of fatigue and high levels of depression or anxiety. 3 of these studies are pretty large size studies, and they are all reporting that if you have or if you experience financial toxicity, you are 3 times more likely compared to people who don't have financial toxicity to experience depression or anxiety. What we also found, though, was that there's some beginning evidence that financial toxicity is, there is a relationship between financial toxicity and some of the other symptom burden, including physical symptoms. But many of these studies actually did not specifically identify the relationships between financial toxicity and physical effects. And as a group, we started beginning to hypothesize that if someone is actually experiencing high level of distress, and how actually stress can actually contribute to symptom burden, in particular physical symptoms in the human body, but also the inability to be able to have the finances for care, whether they would actually subsequently also have an impact on the physical symptoms as well. So at the stage, they were all quite hypothetical. So we actually began to decide to explore this area to see how we can actually, first of all, identify people with financial toxicity, and second of all, to understand whether there is a link between financial toxicity and physical symptoms. So in this particular work, it's a pretty new article that we published in BMJ, Supportive and Palliative Care, whereby we used latent profile analysis to look at breast cancer patients from the beginning of diagnosis, very early on in the diagnosis, prior to the surgery, with 391 women with breast cancer, and to follow them up and to look at their financial distress profile. We asked people to rate their financial distress from 0 to 10. And the significance of this work is that my senior colleague here, Christine Maskowski, has been doing a lot of work using the latent profile analysis to identify distinct profiles in patients who experience symptom burden over time. And applying the same method on financial toxicity is very helpful, because this exercise actually told us that there are actually 3 very distinct groups of patients. When you actually, for example, when you actually see all these women in the clinic, there are 3 distinct profiles of financial distress, whereby there is a group of around 14.6% of people who actually had no financial distress whatsoever. And then you have a group that is pretty low, from 0, hovering around 2 out of 10 of financial distress, of 0 being no distress at all, and 10 being totally financial distressed. And then you have got a pretty high group who actually started around 6, and then they actually hover around between 6 to 8 throughout the entire time, and that's around 32% of those people. So what this is really telling us is that if we are beginning to identify our resources and allocate our resources to begin to address financial toxicity or the impacts of financial toxicity, we should really find this high group in understanding how we can actually begin to help these people. The next slide here, what we actually subsequently did was to look at all these, the memberships of these three groups, to look at what were the characteristics, the factors that really characterize this high group to help us screen these patients and identify these patients. And interestingly, what we found was that this approximately 33% of people, so 1/3 of the cohort, actually reported higher fatigue, higher sleep disturbance, state trait anxiety, depression symptom, as well as cognitive impairment scores. And of course, they also report lower quality of life scores as well. So this exercise really allows us to identify what characterized them, but it also tells us that that there is a relationship between higher financial toxicity and actually higher symptom burden. So once we get better at identifying these patients, what are some of the potential things that we can begin to do for them or with them? Some of the examples might be, and of course they vary depending on context, we need to advocate for information and for disclosure about efficacy and cost of treatment. We can potentially reduce unnecessary travels for people who are traveling for low-value treatments or care. We can potentially reduce follow-up care that are done face-to-face and actually conduct them via telehealth. And of course, COVID has really helped us rapidly encourage that, but I still think that we need to be really thoughtful around what are some of the appointments that we really want to be replaced and which ones are the ones that we really don't want necessarily to be done in telehealth. And we need to have further evidence to help us understand a little bit more about the implication of physical examination, for example, which is very difficult and challenging to be conducted over telehealth. Supporting patients to engage in employment or return to work after cancer, providing intervention to people who experience high level of financial related stress, channeling people, referring people for financial counseling where it is available. So a number of things that we could potentially begin to think about to do depending on the context that we are in. So just in conclusion, there is definitely further scope for us to use research to inform policy and practice around the globe. And we really need to think about the context, which is very important. Advances in research quality and methods are key. We need to be very carefully plan about the next stage, about what do we really need to do in the literature to drive this, to drive the knowledge forward, but also to practice practical solutions. We need to continue to monitor financial toxicity both at the system level as well as the patient level. Continuing to monitor that would help us continue to highlight the importance of actually addressing it. And of course, we really need to think about how we can actually support these patients a lot better at different levels. So once again, thank you so much for inviting me and involving me. It is a true honor to be representing MASCC at the OncoAlert Colloquium. And once again, I'm the chair for the MASCC survivorship group, and we're a passionate group of people who try to improve outcomes for our patients, and we would love to have you joining forces with us. Thank you very much.
Ladies and gentlemen, my name is Florian Scotte. I'm a medical oncologist at Gustave Roussy Cancer Center in France, and it's my great privilege to discuss the topic supportive care here with digital health for the OncoAlert Colloquium. I have no disclosure related to this topic. In the agenda, I will first discuss 3 oral presentations during the ASCO meeting, and then 2 publications on the digital health. So first of all, during this ASCO meeting, monitoring platforms have been highlighted with 3 very outstanding studies. The first one, Capri, assessed an organizational model which associates a team of nurse coordinators with a digital platform. The second one is eRapid. It's a trial that allows a self-evaluation of the patient with regard to side effects. And then the chemotherapy remote care monitoring program, which provides text messages in order to monitor nausea and vomiting to reduce emergency situations. So the first study, Capri study, combined nurse navigator program with a mobile application on the digital website, and it was compared to the standard of care for patients under oral treatment against their cancer. It was a monocentric randomized phase 3 trial. As you can see, randomization 1-to-1 standard of care versus nurse navigator plus dedicated website. The patient will alert the nurses via the website in the case of an adverse event related to its treatment, and then the reaction is to call the GP or to propose the patient to go to the emergency department or to go back to the oncologist. The primary endpoint was the relative dose intensity at 6 months. The secondary endpoints were the adherence, the grade 3 and 4 toxicity level, the patient's experience, the quality of life, economic resources, and survival. So in terms of results, as you can see on that slide, the primary endpoint reached the significancy. So it's a very interesting result. And for the secondary endpoints, as you can see, there was a decrease in grades 3 and 4, specifically on skin toxicities, metabolic and nutritional toxicities with significant results. In terms of emergency visits, there was also a significant decrease. So this application allows a reduction of emergency situations in terms of visits as well as grade 3 and 4. To the other secondary endpoints, there was an increase of the use of supportive care resources, as you can see on that slide, from 35% in the control cohort to 44%. It was also significant, and as you can see, it was specifically seen for the social worker assessment. It was disappointed for progression-free survival and overall survival without significant effect, but the power was unmet with only 650 patients enrolled in the study. So we were waiting for more than 800 patients. The second study is a phase 3 randomized control study, which assess the impact of a e-health intervention during chemotherapy. So patients under chemotherapy for breast or gynecologic or colorectal cancer, early or advanced, were randomized 1-to-1 between 2 cohorts. The first one with standard of care, the second one with eRapid plus standard of care over 18 weeks. The assessment was performed at week 6, week 12, and week 18 on quality of life, FACT PWB, self-confidence, cost, and professional impact with contacts and hospitalization. So the standard of care was represented by hospital acute services as well as nursing support, and the primary endpoint with a 2-point difference in the FACT PWB. So this is the intervention. As you can see, the patient will answer a questionnaire, and depending the evolution of the cancer cause, cancer treatment, we can have curves in order to monitor the different symptoms, temperature, mucositis, nausea, and vomiting, for example. So in terms of primary endpoint, as you can see on the table and column, there was an improvement of symptom control the first 3 months with significant results at 6 weeks and 12 weeks. The significance was not met at 18 weeks. In terms of secondary endpoint, as you can see, more than 18,000 symptoms alert, and mostly fatigue, physical activity, limitation, pain, and anorexia. There was a significant result on self-control. In terms of quality of life, it was met at 18 weeks for the EQVAS. It was also met for KLQC30 at week 12, but not on fact general. The third study was the chemotherapy remote care monitoring program, which sent an SMS, a sharing platform of SMS between patient and pharmacist. And the purpose was to identify patients who need an intervention for chemotherapy-induced nausea and vomiting. So as you can see on that side, it's the program. So the patient will receive his chemotherapy infusion, then he sends a daily text for 1 week with responses sent to the pharmacist with an action or not, depending the symptoms. This program will follow the MASCC tool, expect 1 question on hydration, how many glasses or liquid have you been able to drink? So it's over the MASCC tool. All of the questions are included in this tool. In terms of results, as you can see, close to 400 patients enrolled in that study on 6 months only, with 861 cycles in total, with a response rate very interesting, 94% of patients. The characteristics are seen on that table. You can see that half of the patients received curative therapeutic intent and half of them were in a metastatic situation. In terms of chemotherapy regimen, as you can see, 30% of them received cisplatin and 25% carboplatin. So more than 50% of patients will receive high hematogenic chemotherapy or a high level of moderate hematogenic chemotherapy. So 7% of patients answered yes to vomiting and 33% yes to nausea. As you can see, there was no impact of the SMS use in terms of decrease of nausea related admission as well as nausea related emergencies. But the global emergency visits were significantly reduced using this SMS sent to pharmacists. So the conclusion is that text messages limit emergency visits but have no impact on nausea and vomiting. So I will now discuss the publications. We have 2 publications this year really interesting in the topic of digital health. The first one was Capri COVID. The second one was a review of publications on digital health help. So the first one, the effects of internet-based psycho-educational interventions on mental health and quality of life among cancer patients. That was a systematic review and a meta-analysis from Chinese authors. As you can see, 868 citations were could be included in the review, but only 7 were eligible for the study. They combined 1,220 participants for 7 programs, 5 website programs, 1 email counseling, and 1 single session psychoeducational intervention. The results are here. There was an impact in cancer patients of the interventions in terms of fatigue and depression with significant results, really with a very good rate against fatigue. But there was no evidence of any effects of this internet-based intervention on distress as well as quality of life. There are many barriers. Probably the blinding of participants and the personnel can be seen as a high risk of bias. The second study was published in the European Journal of Cancer this year, of course, a patient-reported.com platform, a useful tool to improve monitoring and effective management of COVID-19 positive patients with cancer. It was mandatory to discuss COVID-19 this year, as you may know, of course, and using the Capri example that has been presented during the ASCO. It was the first study presented during this talk. We moved this application to monitor COVID patients. So it was, as you can see, an application on smartphone where patient could answer to 7 questions, 7 symptomatic questions to monitor their symptoms daily. They just had to answer yes or no to the question. If they had cough, fever, pain, dysosmia, for example, then they were monitored by the nurse navigators. And in the case of OncoAlert, so the nurse navigators propose the patients to move to the emergency room. So this is the algorithm that you can see on that side, depending the patient is positive or negative to COVID. All patients previously hospitalized in Gustave Roussy were enrolled in this program. So they had to daily answer to the different questions, depending their compliance or not. If they were not compliant, so the nurse called them daily. So we had an interesting result, and I think that it was really an opportunity to better monitor our patients, our frail patients who were contaminated by COVID and who also had their cancer disease. So thank you very much for your attention. Please attend the 2021 MASCC ISO annual meeting. It will be in Seville in June, next June 22 and 26. We hope to have an in-person meeting and to be able to meet everyone face to face, but maybe it would be mandatory to have a digital or hybrid meeting. Thank you very much for your attention.
Thank you all for joining us today, and don't forget to join us tomorrow for day 2 of the Colloquium. We will be discussing the best of 2020 in lung cancer and the COG sessions with great presenters like Dr. Solange Peters, Dr. Henning Willers, Dr. Alicia Sequist, Dr. Stephen Liu, Ms. Jill Fellman, Dr. Ravi Kinesvaran, and Dr. Nicola Battisti. Remember that regardless of geography, we're all on OncoAlert.